He lost his arm. And I had thought, okay, as a physical therapist, my goal is to get him surgery. He'd have his residual limb shaped, and then he'd get a prosthetic, and then the therapist would work with him and would come back and refit it. This whole process was going to take a while, obviously, and he'd have the prosthesis for the rest of his life. So I thought, all right, now if I'm to give him the money, at what point do I say that we have met success? And at what point do I follow? How long do I follow this person? What is practical in terms of helping him, but also the next kid that's going to need it? And I realized that the most vulnerable time when I talked to the mom was getting into the hospital. Hi, everyone. My name is Gayaty Mathur. I'm the founder and CEO of the Soondra Foundation, and you're listening to the Public Health Insights podcast.
From PHI Media, I'm Gordon Thane, and this is Medical Emergencies, Financial Catastrophes, and India's Hope, Episode 207, A Beacon for Healthcare Equity in India, the Soondra Foundation. This is the final part in a 3-part series, where we wrap up a captivating conversation with Gayaty Mathur.
You're listening to the Public Health Insight Podcast, your go-to space for all things public health and global health, from the Sustainable Development Goals to the social determinants of health, as well as interesting dialogues about the diverse career opportunities that exist in these fields. Remember to subscribe to the podcast and leave us a rating on Apple Podcasts and Spotify so other people like you can benefit from our content.
Originally from Mumbai, Gayaty found her calling in 2018 when she founded the Soondra Foundation to reach more families in need of financial support for unseen medical emergencies. Even during the challenging times of the pandemic, the foundation continued its crucial work, covering the cost of out-of-pocket medical expenses and providing food rations to targeted families in India. Gayaty talks about the mission of her foundation and the story behind the name Soondra.
So our mission is to provide cash grants to India's working poor when they have a medical emergency. Soondra was my family's housekeeper for me when I was growing up. So she came into our family before I was born, actually. I have an older brother. So when he was a toddler, she came into the home. And by the time I got there, she was already very much a member of the family and continued to be a member of the family and saw my children even. So that was amazing. She passed, unfortunately, a few years ago. But she was, a woman from rural Maharashtra, which is the state that Mumbai is in. And she lost her husband soon after she got married. And in those years, there was a lot of prejudice and stigma around being a widow. And she said, forget this. I'm not going to subject myself to this life. She chose to come to Mumbai, earn her own living, and make a life for herself. So, which is why she ended up with our family. And she was an amazing woman. She was funny and caring and affectionate. She had a ready laugh. And really, I'm honoring her memory, her love with this foundation, because that's the demographic that we want to serve. Today's people who are house help, who are auto rickshaw drivers, who are vegetable sellers, who are construction day laborers, people who are working poor, who are daily wage earners, who don't have the financial capacity to have any savings, but are working hard, are doing their jobs and serving the rest of us. So when they have some sort of medical emergency, I want to help them. I want to be there for them. And Soondra is the person that I want to honor through this work.
The Soondra Foundation is based in Chicago, in the US. And with the beneficiaries of the foundation's work being in India, Gayaty pulls back the curtain to share how the foundation got off the ground and how it currently operates, partnering with existing networks on the ground in India.
As I mentioned, I was a physical therapist and had absolutely no idea. And, I had gotten to the point, obviously, in my career where I was the expert in the room, and I had people coming to me to ask for clinical advice on how to deal with problems or patients or whatever. But I realized that in this area of wanting to do something about the problem, I was a complete novice. I had actually applied, and then I got incubated at the University of Chicago's Polsky Exchange. So they had, I think this program stopped during COVID, like so many other things, but they had an incubator. And I was the only nonprofit in my cohort. But because I was the only nonprofit, I was surrounded by people who were talking business, were thinking in best practices ways to set up their business. And that really helped me think about best practices before I really set up my nonprofit. And I realized that instead of reinventing the wheel and having an outfit in India, I wanted to utilize the Indian ecosystem that exists today. There are amazing nonprofits that work on the ground. They are there. I am in Chicago. I'll never be able to compete, or not that I want to compete with them, but in fact, I'll never be able to reach the level of expertise as them because they are there 24/7. So I decided that I would help their mission by providing a partnership with them to help with this specific issue of healthcare access. So we have a partner, as I said, that's an educational partner. They have schools all over India. And if one of their children falls sick, then their teacher knows that this child is actually sick and can be the point person for the deployment of the entire machinery to get the child to the hospital, get the funds out there for that particular thing. So we don't give money to the family. We give money for the treatment, for what the kid or the adult needs. We also work with a blood cancer provider, for example. When the person comes from all over India, they come to this particular hospital. The doctors determine what is their medical need. The social workers know the financial need, and they have to commit to the treatment. And once those criteria are met, we really decentralize the decision making. So I, up here in Chicago, me and my team, we don't have to make the decision. We leave it up to them because they know best how to apply that. Of course, we give them the criteria, but once those criteria are met, they get to deploy the funds in the best way that they need to for the patients. And again, the patients don't receive the money in their hands, they receive the care as a result of the money. So I feel that we're helping them with their mission. It also helps us because that's 100% accountable and transparent. We literally know where every single dollar is spent and how every single dollar is spent. So it's about being part of a change system, right? I'm not just on my own because I cannot. Soondra then plugs into these very amazing nonprofits that are already doing this work and lifts their mission too. Because if the mission is to educate a child, if the child is not, the butt is not in the seat, where is the education going to happen? So through the medical issues, through whatever it depends on whatever the partner is working on. It also gives us the ability to work with a variety of different kinds of partners. And then we don't have to worry about coming off the street and trying to take our money in a way that we cannot control.
Fundraising and getting money to people in need across international borders is not as easy as it sounds, especially for someone who has not had prior experience running a foundation. There are many considerations that need to be taken into account when money is changing hands, even in the context of a charitable foundation.
Obviously, the US and India has anti-terrorism and money laundering laws. So when money is crossing borders, we have to consider all these things. If we work with a big partner, they have to have a license that the Indian government requires. And once they have that license, we also know that A, they have the license, they are allowed to receive the funds, but number two, that they have the accounting infrastructure, the legal infrastructure to receive the funds and account for it. So that solves our problem automatically. So I really spent a lot of time to set this process up in a best practices way, not only in terms of the logistics, but also in terms of the way we conduct our nonprofit through equitable terms and through terms that we actually bring change at the grassroots level, that we rely on grassroots people. We're not going down there and wagging our finger and saying, you have to do things this way, because we are sitting in Chicago. The folks over there know exactly what's going on, and we rely on them, to do things in the best way for their best interests, for their clients' best interest, or their constituents' best interest.
Behind the scenes, there was a lot of thought put into developing the model for the Soondra Foundation. The foundation remained resilient even in the face of COVID-19, which followed about 2 years after the launch.
So it's really worked out really well. And the validation came during COVID because many nonprofits couldn't work at all. We, on the other hand, had the other problem. We could have given more money if we had had it. We were really short on not being able to do it, but being small at the time, we were able to limit only according to the money that we had. If we had $5 million, we would have given that away too during COVID, because that was the system that we set up that worked basically on the grassroots level.
Throughout our conversation, there's something my mind just kept going back to, and something that I need answers to. Of all the different ways charitable organizations can support people, why did she ultimately decide to provide direct cash grants for medical emergencies?
So Gayayti, it's really clear how intentional, even the way that you're describing it, with providing direct cash grants for medical emergencies. You talked about other partners on the ground that are doing various things that you wanted not to step on any toes, but more of an asset-based approach to the foundation. So walk me through your discovery to landing specifically at providing direct cash grants. Of all the challenges that surround people getting medical care, whether it's transportation and all these different components, how did you land specifically on, I'm just going to focus on providing direct cash grants for medical procedures and medical emergencies?
Yeah, there were many inputs into that. As I said, being part of an incubator that thought about best practices was one big aspect of it. Another aspect was a book that I had read. Actually, my son was studying economics at the time at university, and he'd had a class, and this book is called, I think it's called Poor Economics by Abhijit Banerjee and Esther Duflo. That was the textbook in the class, and he had said, this is really a cool book. And I read that from cover to cover, which sounds so idiotic, but it was amazing because I'm not an economist. I didn't even think I would understand it. But I understood every bit of it because it was very research-based. I've said to you, I've got a research background. And that showed me that a lot of folks who are in this situation act rationally for their situation. So if you are going to help someone, you have to help them for what they need, not what I want to give them.
Gayayti illustrates the importance of providing people with assistance in ways that they would find the most beneficial, including ensuring the conditions for people not to delay that first hospital or clinic visit, ensuring that families receive medical care without the looming thought of finances prevents a cascade of events that could impact the individual, not only the one that needs the medical help, but the rest of the family for generations to come.
So that was a big portion of understanding, what does the consumer need? What does this particular person need? And I realized that the story that I told you earlier, when I had my mom's maid whose kid fell sick, that was still in the background. And I started talking to people, and I met a kid who was playing cricket. And in the street, he was playing cricket, and he picked up a ball and by mistake touched a live wire. So he lost his arm. And I had thought, okay, as a physical therapist, my goal is to get him, he'd have surgery, obviously. He'd have his residual limb shaped, and then he'd get a prosthetic, and then the therapist would work with him and would come back and refit it. This whole process was going to take a while, obviously, and he'd have the prosthesis for the rest of his life. So I thought, all right, now if I'm to give him the money, at what point do I say that we have met success? And at what point do I follow? How long do I follow this person? What is practical in terms of helping him, but also the next kid that's going to need it? And I realized that the most vulnerable time when I talked to the mom was getting into the hospital. Because if he hadn't had that, none of it would have followed. It also happens, for example, with our blood cancer patients. They come from all over India. They have almost no money in their pockets. Now, they have come from some rural town, a few hundred kilometers away from the center that they're going to. And the doctor in their village said, oh, first he would have just given them some medication. And 2 weeks later, he still has a fever. And the doctor then does some basic blood work and says, oh, you have the big sick, you'd better go to such and so hospital in such and so big city because they have the solutions there and we can't help you here at all. So they've literally reached 3 or 4 weeks after their initial diagnosis or initially falling sick. They are extremely ill. They have no resources. And if they are to recover in any way, the first thing that they have to do is get into the door. And that's what I decided. And the other reason, of course, as I said, it's a 1-2 punch. You don't have money and you can't get into the hospital. But if you get into the hospital and you give money to get in the hospital, you've also prevented that financial catastrophe so that you don't have to sell a cow. You don't have to sell the piece of land. So it seemed to me a couple of things. Number one, we could say that we were successful as soon as they got into the hospital. The check mark was we got them admitted or got them to see a doctor. Number two, it was also a financial problem that was prevented. And then you got them into a system. So now, for example, with the blood cancer patient, yes, they've got their first antibiotic, first chemo. The local system, the local NGOs, the local social workers, they now help these folks get the certification that they need, get all the paperwork done. It's bought them time. So the $250 that we have given them for admission translates for them into $8,000 over the course of the year, which we don't even give. We just gave that first admission money, but they get all this money for the rest of the year's treatment, accommodation, everything that they need because of that small amount of money that we gave and because we got them into the hospital. Then the local system has the ability to move its wheels and get things going to get resources for these folks. So I thought this is the injection of capital that's going to solve multiple problems. It's a small amount of money or relatively small amount of money. Sometimes it's actually even $25 for just a simple fracture that doesn't need anything else. Sometimes it's $250, sometimes it's $400-500. Usually in blood cancer, it varies between $250 and $450. But for a relatively small amount of money, you have given this family, if it's an earning member, and usually there are people who are, in their early 30s, up to their early 30s, where they are diagnosed with blood cancer, whether it's a mother, given her children a whole lifetime of being supported. If it's the father, that's the income for the whole family. So you have a very long impact with this tiny amount of money at the right time. And that's how I honed in on that particular problem, if that makes sense.
What we learned here is not just the immediate impact of what providing cash grants can bring for the health of the person in need, but its overall importance. Let's say a parent or a caregiver delays urgent life-saving medical attention as a result of anticipated financial consequences. If this parent was then to tragically die, this family loses an earner who contributes to the overall household income. This can set back a family for the rest of their lives and increase the likelihood that even subsequent generations will experience poverty. Gayaty talks about what the typical cost is for someone receiving medical care through the public system And how many families the Soondra Foundation helps every year?
Yes, so as I had mentioned, it costs us anywhere between $25 to $1,000. We give $1,500 maximum for a patient, and part of that is so that we can give many people that initial money. I've done a lot of research initially, and if we get them into a public health system, into the public hospital system in India, $1,500 basically pays for pretty much everything. Like I mentioned, the ICU patient, that was actually one of the few that we have given $1,500 to. The other thing that is happening now is that we're getting people with more complicated situations. For example, we have a child who has perhaps spinal cord injury and spina bifida, and it wasn't even diagnosed till he was much older. So there were jaundice, people who have jaundice who are very, very ill, or other more complicated situations with serious typhoid. When they need admission, it's not just a case of antibiotics. So we're getting more complicated cases as the situation is getting more understood at the level of the nonprofit that we're working with. But generally, we give a maximum of $1,500. The average amount of money is about $200. The median is probably $300. So there's quite a range in terms of each individual grant. How many families we help? We probably help about 100 families a year right now. Of course, I would love to add a zero to that. That means we're looking for funders, and particularly we're looking for funders who will walk with us, who will think of us as partners and come and help us with our programming, with supporting our nonprofit partners in India. So that's in terms of some of the big numbers that we do. We work with some two or three. We work with nonprofits very regularly, and on a regular basis we're receiving their inputs. We need help for this problem or the other problem, and some are more sporadic. So we have about 6 partners in total, and as I said, overall we probably help about 110 families a year.
As of right now, at the beginning of 2024, the Soondra Foundation helps just over 100 families every year. And as you can hear from Gayatry's commitment to the mission in the conversation, she wants to help even more people. But beyond that, she's hoping for something even more. A day where her foundation is no longer needed.
I would love to be able to help more families. I mean, I think that is the bottom line. I would love to service all our partners completely, grow our partnerships. Everything isn't about scale always. Of course, I hope to not need to do this. That's my hope. If you ask me, what do I want in 20 years? I want Soondra Foundation to be redundant. That would really be my goal, that we don't need this help. But till then, yes, the more funding that we can get, the more families that we can help would be the way to move forward. Absolutely.
That's great. You're probably the second person I've ever heard say something like that, where if my company or organization or foundation does well enough, we shouldn't be needed anymore. And I think that's a very powerful message, which we'll end on that note. So thanks, Gayaty, for coming and sharing your insights on what it looks like in India, how the Soondra Foundation is supporting medical care for families, and a little bit about yourself as well, which we very much appreciate.
It was a pleasure to be with you. It was fun to be with you as well, and thank you for the opportunity again.
This show was edited by me, Gordon Thane, with additional editing from LaShawn Benedict. Sound design and mixing by myself and LaShawn Benedict. The original music from The Music Room, composed by Tom Fox, licensed from Johnny Harris. The cover art designed for our show by LaShawn Benedict. The Public Health Insight Podcast is produced by PHI Media.
Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our podcast, be sure to subscribe and leave us a rating on Apple Podcasts or Spotify. See you in the next one.